Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of welcoming back to the podcast Professor David Cibula, dear friend and colleague, someone that obviously we all respect in the field of gynecologic oncology. Professor David Cibula is at the Gynecologic Oncology Center in the Department of Obstetrics and Gynecology at the First Faculty of Medicine, Charles University, and General University Hospital in Prague in the Czech Republic. And of course, obviously, today we're going to be speaking about a key study, a very long awaited study. We all wanted to know the results, titled The Sentinel Lymph Node Biopsy Without Systematic Pelvic Lymphadenectomy in Females with Early Stage Cervical Cancer, Final Outcome of the SENTIX Prospective Single Arm Non-Inferiority International Trial that was published in Nature Cancer. David, thank you so much. It's great to see you again. Thank you for accepting our invitation to the podcast and really looking forward to discussing this really important article.
Pedro, thank you for the invitation. I'm very pleased to be with you here in the podcast, and also, and even more, I'm pleased to discuss the SENTIX, of course.
Fantastic. So, wanted to start by discussing what do the guidelines tell us about sentinel lymph node versus full lymphadenectomy in patients with cervical cancer today?
Well, this depends a little bit on the update date of the guidelines. So, as we know, NCCN guidelines, very strong aspect of it that it's regularly updated. And they are also quite inclusive. So in NCCN guidelines, in early stage cervical cancer, you have both options, like options. So either sentinel lymph node biopsy only or systematic lymphadenectomy, even plus minus parotic lymphadenectomy. So there is everything included. In the European guidelines, it was already 2 years ago when they were published, there is still a standard sentinel lymph node in 1B stage. It says that if it's negative on frozen section or it's negative macroscopically, then full lymphadenectomy. But as a preliminary information, those guidelines, which are currently under the development in Europe, ESGO resource stratified guidelines and ESMO guidelines. Of course, it has not been published yet, but there should be already SLN biopsy as a standard procedure for tumors below certain size.
Excellent. Thank you for that introduction. Now let's talk a little bit about SENTIX. Quite a study, 47 sites, I believe 18 countries. This is an international observational study. Can you tell us a little bit about your inclusion criteria and also your endpoints?
Yeah. Well, so the patients with squamous cell HPV-associated adenocarcinomas were eligible. The first part, we also include patients with adenosquamous cancer, but then by amendment, we stopped that. So it's not, complete. Less than 4 centimeter in size. And what was important that bilateral detection of sentinel lymph nodes was inclusion criteria. So those which failed, even on one side, were excluded. This was done because we should understand the study was designed in 2015-16. So we were really at the very beginning of that era, and we wanted to be really sure that the best candidates are included only. So bilateral detection and also negative frozen section. So all sentinels were sent for frozen section, and if this was negative, then it was a prerequisite for inclusion to the study.
Amazing. And, as you mentioned, this study started in 2015, 2016, consistently surgical trials in gynecologic oncology. They all seem to take on that range, 8 to 10 years. So obviously a long time of dedicated efforts. by physicians and also by patients. So thank you for completing it and reporting it here. So now let's talk about the results, because we have a lot of questions that we want to go over and get into some of that granular details. What would you want to highlight as the results of the SENTIX trial?
Thank you for that question. So, uh, in a, normally you start with the primary endpoint in each study, and I would start with another outcome of the study, because I consider it even more important, and this I consider an essence of this field, because one of the highlights for us was from the beginning the quality of sentinel lymph node pathology. Uh, uh, a lot of people before us concentrated on detection of sentinel lymph nodes, but if you detect it, you detect it. So for us, we were very inclusive in that part. Any tracer was eligible, any surgical approach was eligible. At the same time, we're very strict when it came to the quality of pathology, because we consider this as a very crucial element to have really good ultra staging. And I can tell you later that it was a very interesting lesson for us, because we did even central control quality. So we moved specimen from all these 47 sites to Prague, and we check the quality of ultra staging. But why I'm speaking about it, that for me the main outcome is that almost 50% of positive lymph nodes, calculating only macro and micro metastases, were detected by ultra staging, not by frozen section. So, in general, lymph node staging in cervical cancer, we do for staging purposes. The aim is to identify high-risk group with positive lymph nodes who will then receive adjuvant treatment. And by sentinel lymph nodes, we double the number of patients with positive lymph nodes. So those patients would normally stay in lymph node negative patients. So this is for me the main message. And then of course the second, because the study was designed for recurrence-free survival. The endpoint, the primary endpoint, was recurrence rate at 2 years, and the study was positive, meaning that there was non-inferiority. And since it was observational trial, we compared the data with the historical cohorts. And yes, this is the main weakness of the study in terms of evidence. At the same time, we were, our rationale was that there are massive cohorts with good outcome data from patients who had a full lymphadenectomy. So there were, thousands of patients with the outcome data. And just to be one interesting point, that if you consider other gynae cancers, so where are we now? In vulva cancer, nobody questions sentinel lymph node. Based on what? Based on one observational trial, and the endpoint is calculated on 250 patients. That's it. Endometrial cancer, observational data. We have no prospective randomized trial which would confirm safety, I mean oncological outcome, and compare sentinel lymph node and lymphadenectomy. Those are only observational data, and the data are smaller than that. In cervix, we have randomized SENTICOL, we have large observational SENTIX data, 600 patients, And recently we have even Chinese trial. But we have, what I want to say is that we still question the evidence which we have in SENTIX, but in reality the evidence is better than we have for endometrium and vulva, in which we freely and happily accept sentinel lymph node biopsy only.
Yeah, so well, well said, and certainly again we treasure the value that is offered by studies like SENTIX, as you mentioned, where you learn multiple points regarding the question of interest or related topics of interest, and I have to commend you and the team, and having worked with you and your pathology team before, really outstanding that such detailed analyses of the sentinel lymph nodes was done. So congratulations on that as well. So now, David, as you know, we often will have questions from our fellows in the journal. So we will start with Helena Obermeyer from Sydney, Australia. And she's asking about the surgical quality. You spoke a little bit about it, but specifically, she says the study required participating centers to have prior experience with at least 15 sentinel lymph nodes procedures in gynecologic cancer and to treat a minimum of 10 early stage cervical cancer patients per year. Given these thresholds, do you think a surgical learning curve may still have influenced outcomes, particularly in centers newer to sentinel lymph node biopsy in cervical cancer?
Yeah. Well, once we speak about surgical trials, the quality, of course, is very important, and it's not easy because how to measure the quality of surgery. The quality assurance is always complicated. If you look to these 15 sentinel lymph node procedures, from nowadays perspective, is very low. It looked like we were very unambitious, but again, look at it from the perspective of 2016. So this was some threshold which we knew is realistic, and we are also this was from the beginning an adventure, because we started to rely on sentinel lymph nodes and try to understand that we were receiving questions. But David, some patients may then recur in the pelvis. What we will do? I said, yeah, they will definitely recur. But this is the principle of the study. So these people were really scared not to do complete lymphadenectomy at that time. But finally, what we showed in the study, that our detection rate, bilateral detection rate, was highest. I think that it was highest in the era of cervical cancer trials, because it was 92 point something percent. So it was really very, very high. And I think that one of the reasons was that we were actually inclusive, that we say, you can use any technique which you are experienced with. So if you are experienced, if you feel comfortable with blue dye plus technetium, use it. If you are experienced with technetium, use it. If you use ICG, use it. So we didn't force them that because of the study they have to use something what they might not be that experienced.
Mm.
So it worked well. And concerning the learning curve, interestingly, because we analyzed that also, actually, we were quite successful with the enrollment, because we enrolled all these 730 patients within 5 years. So it was quite quick. Then we wait for the follow-up, and we didn't find any trend. But at the same time, if you have so high detection rate, 92%, it's difficult to find trends, because the differences are small then.
Well, David, now you mentioned previously about the study design. Filippo Capomacchia from Candiolo Cancer Institute in Italy, he wants to ask you, in your study, the SENTIX trial, you did not include a randomized control arm undergoing systematic pelvic lymph node dissection. Can you explain your thought process and your considerations when you were designing the study?
Yeah. Well, there is interesting background because first proposal of the SENTIX trial was as randomized control trial. First proposal of French Cervical trial was an observational trial. And then French were forced by the French Cancer Grant Agency that if they want money, they have to change it into RCT. Otherwise, they won't sponsor the study. And contrary, we were advised by ENGOT group, the network of here European societies, European oncogyne centers, to change it into the observational one independently. So at the end, we end up with observational one, and they did randomized control study. Definitely, observational one is easier. So it was faster, with the initiation, with that was faster, and this was from our perspective because we thought, yeah, let's see, the other fields, vulva cancer, endometrial cancer, everything is based on observational study. We have massive data from patients who underwent full lymphadenectomy. So we thought that observational trial might be sufficient. I think that nowadays situation is very good because we have data from the first observational, we have data from the first randomized trial in China, and we are awaiting confirmation from randomized trial, international Cervical trial.
Great. Now, going back to Helena Overmeyer, she's interested in the actual surgical technique and decision making by the surgeons. And she's asking, was there a standardized sentinel lymph node protocol across all sites? And you already mentioned about the tracer. How was adherence to that protocol evaluated given the multiple centers and the nature of the trial? How did you address or control the heterogeneity from surgeon to surgeon in terms of their technique and what they were thinking in terms of the intraoperative decision making?
Yeah. Well, we, as said, we focused, if I take it as two different fields, surgical field and pathology field, because both are very much involved in sentinel lymph node biopsy concept as such, we more concentrated on the quality of pathology because we felt this is the crucial aspect. While the surgical aspect, yes, we had a teaching film which was available. So we filmed, we narrated the step by step the procedure, and this was available for all the sites. And we also spent quite a lot of time, and this is another important message and another important experience for us, with really real-time data monitoring. So from the beginning, we dedicated one monitor for the SENTIX trial for the whole duration of the trial, and she really searched for the data. So we were in contact with individual site. As an example, we saw one site that they have 14 sentinel lymph nodes. So it was obvious that there is something wrong with their understanding of the concept. Then we thought that there were really lapses, big lapses in the pathology ultra staging. So again, we were in contact with the site. So from this perspective, there has been a lot of improvements during at least the first part of the trial.
Yeah. Now let's turn a little bit into the oncologic outcomes. Reem Abu Chakra from Lebanon, she's asking, why did you select 2 years follow-up as the primary endpoint for recurrence rather than 3 or 5? How can this be an underestimate of the true long, could this be an underestimate of the true long-term recurrence risk?
Yeah. Well, if you read the article, there are all the data available. So median follow-up time in the study was 47 months. It's not 24, it's 47. If we say that the primary endpoint is calculated for recurrence rate at 24, meaning that all the patients had to reach these 24 months. So it's a minimum. So in the article, there is 2-year disease-free survival, 93%. 3-year disease-free survival, 92%. The difference from year 2 to year 3 is quite small. And also, if you look at Kaplan-Meier curves, there is this a steeper decline within the first 2 years, and then it's quite flat. But
Mhm.
I'm not underestimating it, but just to understand that the median follow-up is much longer.
Great. Mariana Carvalho is asking about ICG, and she's asking, do you think that the use of indocyanine green in only 29% of your cases could compromise the study results?
Yeah. Uh, Again, this was quite interesting observation in our trial. I, of course, know the data. I'm well aware that there were even randomized trials comparing ICG with other tracers, showing that ICG is better in detection rate. I agree that ICG improved the detection rate, especially in endometrial cancer patients, in obese patients. Still, I think that our approach was quite reasonable, because if we did it in 2016 and we limited the technology to ICG, a lot of these sites would be excluded because they simply did not have ICG available at that time. The situation definitely has changed, but interestingly, we have, again, in the whole group, we have 92% bilateral detection rate. So it's it cannot be better. You have different hiccups during the technique. So it's really very, very high. And we rather show that really it's important to have experience. And actually, I'm using the data from the SENTIX if I discuss, especially with some hospitals and sites and colleagues from so-called limited resource regions. If they don't have ICG, I say, look at SENTIX.
Mhm.
And
Yeah.
you can, if you have blue dye and you have good experience, if you have blue dye technetium, you can reach very good detection rate. So you can use it. You don't have to purchase ICG. If you have it, good for you, of course. That's the best. But it's not the only way.
Yeah, excellent point. Now back to Rima Buchakra. She's asking, sentinel lymph node biopsy with ultra staging identified 44% of positive cases that would have been missed. What does this imply about the limitations of conventional pelvic lymph node dissection in detecting these low volume metastases?
Well, that's a very good question, and I would rephrase it as such, that if for somebody the data available are still not sufficient for switching from systematic lymphadenectomy to SLN biopsy only, that's okay. But they should do not systematic lymphadenectomy without SLN. So
Mhm.
it should always, the standard always should be SLN plus lymphadenectomy. Because SLN means that this is the selection. SLN means that out of 20, 25, 30 lymph nodes which are removed from the pelvis in medium by systematic procedure, you select two or one or three and send them to pathologists and say, concentrate on those, because those are the lymph nodes with the most with the biggest risk of being positive. So, and that's why they that's the rationale for ultra staging. So this is one of the arguments which I use if again, especially from the some regions, colleagues argue against me and say, but Sentinel, it's expensive. Ultra staging is not available. It's expensive. We will continue doing pelvic lymphadenectomy. So my argument is, so stop sending 25 lymph nodes, because each of them must be cut and evaluated. And as a Bergen, ask your pathologist, for not to do 25 lymph nodes, but for these three, which you will send them as sentinel lymph nodes, do more slices. Excellent. And concentrate on that, because you have much bigger chance to detect mets in these sentinel lymph nodes than in any other pelvic lymph node. So this is not a correct argument, but simply saying SLN should be part of systematic procedure nowadays as well.
Fantastic. Yeah, such an important message. So definitely encourage those who are listening. If there's any time in the podcast to rewind and listen to that again, this is an important message, definitely. So this next couple of questions, several fellows actually asked, beginning with Natalia Tejeda from Barcelona, and we knew this topic was going to be coming up. So David, be careful how you answer these two questions. In the SENTIX trial, minimally invasive surgery was performed in 64% of patients. Could you explain what evidence guided the decision to include patients with stages beyond 1A2 with minimally invasive approach? Additionally, how did you ensure that all participating centers adhered to standardized precautions to minimize tumor spread, such as avoiding uterine manipulators, using protective vaginal maneuvers, enclosure, limiting tumor manipulation during the laparoscopic procedures?
Yeah. No, this is fair remark, of course, and expected question. So, but simple answer to that. They know, and the answer is again in chronology or in a sequencing of the events. So first patient included FBI in the SENTIX trial is July 2016. Date of the LAC trial publication is 2018. You would probably know the months.
October 31st.
And the last patient included was September 22. So the LAC trial came after the middle of the trial. And of course, we had a special meeting of advisory board for this trial. And we discussed what to do with that. And we decided that we will continue, but we issued a letter of warning to the sites. We described, we emphasized the outcome of the LAC trial. We emphasized that we don't know the reason for the increased recurrence rates, especially local recurrence rate. And we advised for switching to open in the next upcoming period of the study. Finally, we end up with this proportion of open versus minimally invasive. I don't think that this is contradictory. What the LAC trial showed was that there might be a risk associated with minimally invasive surgery. It doesn't mean that every laparoscopy or robotic surgery which is performed is associated with the risk, but in general, we did not prove it in our study, which was not, of course, designed and powered for that. But the reason why it happened is quite obvious.
Yeah. And then as a follow-up to that, Sofia Bigardi from Padua University Hospital in Italy, she's asking, unlike the LAC trial, your results showed no significant survival difference between open and minimally invasive. What do you think accounts for this discrepancy between the two studies, and how should this influence current surgical decision making?
Well, I don't think that this aspect of the SENTIX trial will influence current clinical practice. There is level A evidence from the LAC trial on something. Those are observational data which are secondary analysis from the trial. So I believe that now we live in the era when we are waiting for other randomized control prospective trials to be mature, to show us whether it will appear in the other trials, or whether, with all the precautions and all the measures they definitely included in their trials, they can show that with this minimally invasive can be safe.
Yeah. So now, Sofia Bigardi turns to a different point, and I think obviously it's important to discuss adjuvant therapy. So, asking in the SUCOR study, nearly 50% of patients received adjuvant treatment, yet here only about 13% received adjuvant therapy. Where do you think the discrepancy lies and why? And do you think this supports the idea that sentinel lymph node biopsy alone, combined with proper selection, could reduce the need for postoperative treatment?
That's actually very important aspect, and we also paid a lot of attention to that. So it was clearly stated in the protocol that intermediate risk factors, meaning lymph node negative, but a combination of the size with LVSI, because tumors bigger than 4 were not included. So between 2 and 4 plus LVSI or deep stromal invasion. This is not an indication for adjuvant treatment. Um, uh, so uh, so the majority of patients who received adjuvant treatment in the SENTIX trial were patients who were negative on intraoperative assessment of sentinel lymph nodes, but then positive from ultrastaging.
Mhm.
And that's why also the number of patients with macrometastasis was very low, because majority of macromets were excluded intraoperatively. And and as you said, the adjuvant treatment was only received in 11 or 13% in our study, which I believe is a very important part of the concept, because again, we do it for the staging purposes. So our aim is to detect those who should receive adjuvant treatment. And I also consider this as the biggest weakness of the Phoenix Chinese trial, which in my opinion, this really overshadowed the outcome of this otherwise large trial, randomized control trial, fast trial. But they obviously pre-selected very prognostically good group of patients, because their rate of positive lymph nodes was less than 3%.
Mm.
So there was almost nobody, and still they radiated 50% of patients. So they included very small tumors up to 3 centimeters, all of them negative lymph nodes. and they radiated 50% of patients. So what's the purpose of sending a lymph
Right.
node then if you radiate half of your population? So yes, I think it's part of the whole concept to try to separate low risk patients who do not need further treatment from those patients with really serious risk factors who will need a combination of radical surgery with adjuvant therapy.
Yeah. And now to that point also, with regards to the assessment of the lymph nodes, Natalia Tejeda is asking about um, the extent of the assessment. So she's asking patients with positive pelvic sentinel lymph nodes, accurate assessment of para-aortic lymph node status may influence the adjuvant treatment, particularly regarding radiotherapy field design. Did your study evaluate para-aortic lymph node status?
Well, in this respect, cervix cancer is has a lot of characteristics which make it really special tumor, and one of them is very predictable way of spreading. So if we don't count direct invasion into adjacent organs, is a lymphatic spread. You know, try to remember any case which would be lymph node negative with some hematological mets. Such patients do not exist almost. So it's almost always lymphogenic, and it's very predictable. It starts with pelvic, then it goes to common, then it goes to para-aortic, and then anywhere in the body. But it's quite late. And if we keep in mind that we included only patients with tumors up to 4, negative lymph nodes on imaging, and negative lymph nodes on frozen section, the risk of para-aortic was very, very extremely low. And also, we didn't find any when there were few cases who were cured in the retroperitoneal lymph nodes.
Mm. Now, Luisa Prope from the University Hospital in Münster, Germany, she's asking, given the fact that isolated tumor cells were counted here as positive lymph node metastases, how might this have influenced your results? And what's the clinical relevance of this?
Yeah, it was a long discussion, and first, ITC were not considered positive in the first part of the SENTIX trial, and then by the amendment, we changed the policy. Uh, uh, well, we can discuss ITCs. I would love to. It's my beloved topic. But shortly saying no, it wouldn't influence the outcome, because the incidence of ITC is always in any study quite low. So there were only 20 cases with ITC in our study, and we simply, based on the data which we had available, and for this purpose specifically, we made a special retrospective large international analysis of the prognostic impact of ITC. And based on the outcome, we wanted to be on a safer side. So we did a very meticulous ultra staging, and if we found any positivity, ITC or micromets, it was an indication for adjuvant treatment. Keeping in mind that even ITC can be micromets if you really do very, very meticulous dissection of the lymph node.
Okay. Now, let's get into the surveillance. Frederica Stroich from Heidelberg University in Germany, she's asking, can you talk about patient follow-up? Um, Specifically, were there standardized imaging schedules like routine CT or MRI, or was follow-up primarily clinical? How might the intensity and type of follow-up influence the detection of recurrences and thus the results of your study?
Yeah. Again, very good topic, very much discussed at the beginning of the trial, because it was academic trial. we had to follow standard protocols, which were at that time a standard clinical practice. And a routine was imaging only in case of symptoms. So the same applied to the SENTIX trial. There is no doubt that all recurrences in cervix will sooner or later become symptomatic. So we would not miss any recurrence. Yes, I agree. It can delay the detection. So it can influence to some extent the disease-free interval. Uh, at the same time, if you look at the disease-free interval curve, the majority of recurrences appear in the first 2 years.
Hmm. So now, with some of these concluding questions, is about what do we do moving forward? And this question is from Marina Rossano in Milan, and she's asking, you talked about the importance of ultra staging and the standardizing of sentinel lymph nodes. What standards can we put in place in less experienced centers?
Well, uh, just to make it short, I think it's really to have experience with a technique which is available, and again referring to our outcome. If you don't have ICG, it doesn't mean that you cannot detect SLN. You can use other techniques. Blue dye should be currently available elsewhere in the world. It's not a fancy, expensive technique. And there are, nowadays good protocols for the application of the tracer, dissection of the spaces, detection of the first positive lymph nodes. Try not to disrupt too many lymphatic channels, to focus on the removal of the sentinel lymph node. But I would highlight the second point, that what you should do also is to discuss with your pathologist, because as I mentioned at the beginning, we were quite surprised when we started receiving the samples from different institutions, and sometimes we were really badly surprised that even from a very renowned institutions, we received paraffin blocks with half lymph nodes untouched.
Hmm.
And because pathologists did outer staging, but only from one half of the lymph node, or so we realized that that you may think that your pathologists do an excellent job, but it's better to check.
Yeah.
And because this is part of the protocol.
Yeah. So now, Marina is also following up with regards to, given all of the data that we have discussed, and of course now very robust data from the SENTIX trial, do you have any subgroup of patients where you would still say we need to do a full lymphadenectomy over sentinel lymph node mapping?
Well, my answer would be those who were not covered or included in the trials. So if you operate patients with tumors which are about or even above 4 centimeters, tumors which are outside of squamous cell or HPV associated adenocarcinomas, in these patients, I think it's worth doing it. And of course, also, if you do a surgery and during the surgery you find some suspicious lymph nodes, which may happen, then it's outside of the protocol of sentinel lymph node.
So then now, David, Mariana Carvalho from Sao Paulo is asking, what do we do from here on forward? Basically, she said, with the results presented in ASCO 2025 of the Phoenix trial, combined now with this final outcome of the SENTIX trial, would you feel comfortable to change your clinical practice and perform sentinel lymph node biopsy only without pelvic lymphadenectomy for early stage cervical cancer without data from a prospective randomized trial?
My opinion is that yes. My opinion is that yes, we have good evidence. Any evidence is like 100% forever, but we have a good evidence that sentinel lymph node alone, if it's bilateral, with good ultrastaging, is a good alternative. If you compare sentinel lymph node biopsy with lymphadenectomy without SLN, then SLN is definitely much better because of the reasons I've already mentioned. And if, of course, somebody or some site feels uncomfortable, there will be level A evidence data from the SENTIX trial. There will not be, so high adjuvant treatment rate as it was in the Chinese trial, but I strongly believe that the SENTIX trial will simply confirm what is the current evidence.
Well, David, that's the last question. We now have
Yeah.
a tradition of asking a question that was generated by artificial intelligence, AI, of your study. And AI came up with this question. By relying on a historical recurrence rate of 7% as the comparator, rather than a randomized pelvic lymph node dissection control arm, did SENTIX risk overstating non-inferiority? And does this weaken your case for changing international guidelines now rather than waiting for Centicle 3?
Yeah. Well, this is Lancet Oncology question. I no, I fully acknowledge that, and yes, if we consider just evidence according to the levels, then for sure. But once again, it's not the SENTIX. It's the amount of evidence which is much bigger. We have massive data showing high sensitivity of sentinel lymph nodes. So those are data which are not included in the SENTIX. Those are data from historical, large cohorts where SLN was done together with lymphadenectomy. So we were able to compare outcome of SLN and then pathology from all other pelvic lymph nodes. And the sensitivity of SLN, meaning the risk that SLN is negative and any other lymph node, pelvic lymph node is positive, is very tiny, is very low. So that's another evidence. And again, if we speak about staging per procedure, this is what we want to see. And based on these data, we use SLN in endometrial cancer and in vulva cancer. Nowadays, we have even SENTIX, so we have level A evidence. Although, uh, regarding the adjuvant therapy rates, I honestly believe that SENTIX data are more important than the Phoenix one data. And I would also mention one thing is that observational data are also important, and there are good trials and good analysis and review articles in NAME and in other journals comparing outcome of randomized trials and observational data. And in the fields where you have several studies, it's not based on just one trial, which can be biased. It fits to each other very, very well. So usually, if you have like 5 observationals showing something, then the randomized trial confirms it. You can have situation where it was otherwise, but usually it was. So thank you, AI, for this final question. I totally acknowledge this weakness of the trial, but if I don't take it as just a SENTIX, but as the whole evidence which is available, I believe we are already there in cervical cancer.
Well, David, thank you so much. As always, any conversation with you about gynecologic oncology it's a masterclass. So thank you always for engaging in such like thorough and well thought out discussions and answers. Thank you for accepting our invitation. And, really, again, remarkable work in your trajectory and your professional and academic career in gynecologic oncology. And I think I speak for all patients with gynecologic cancers. Thank you for what you have contributed.
It's very kind of you, Pedro. Thank you very much. And thank you to the whole your team because the questions were excellent. Thank you.